Thank you, Chairman. Good afternoon. And of course, when on stage, I will take the opportunity to send my kisses and hugs to Manos and all the team working around them. Just in time, Manos. I'm very grateful to be here and to be a part of Athens Shoulder Course. I will try to say something about how we can predict which tear we can repair and which not. Mouse is not working. Okay, here are my disclosures. So, there are several factors we have to consider. Some of them we can evaluate before the operation, and some of them, of course, will not be possible to say anything about before you're in the OR. So I will try to focus on what we can evaluate before the operation. There will be patients with contraindications for surgery, and there are some clinical evaluations and some radiological evaluations that we have to assess. We all know that there is a relationship between age and if we can make the rotator cuff heal. Increasing age has a negative effect on healing. And we know that re-ruptures of the cuff is very seldom when the patient is younger than 50 years. But after that, it will increase approximately 5% per decade. So if the patient is more than 70 years, you should consider if it's worth trying to repair the cuff or if this will only give the patient time of rehabilitation and maybe it will not heal or you will have a re-tear. What about the smokers? We know that smoking affects both the biomechanical and the histological characteristics of the tendons. And they both affect the rupture and the healing. So some orthopedic surgeons don't want to operate the smokers, but we don't have evidence that say that we should not do it because they will also have a better result after surgery than before. But we can encourage them to stop smoking around the operation. That will probably be good for healing. How about endocrine disorders? We know that long-standing hyperglycemia increases the risk of complications for all kinds of surgery, both infection, but also re-ruptures of tendons. Hyperlipidemia increases the risk of re-rupture. And all these three disorders, hyperglycemia, hyperlipidemia, and hypercholesterolemia, has been proven to degrade the biomechanical properties of the rotator cuff tear in animal studies. It depends on the occupation of your patients, what you must inform them before the operation. In a study from Colleen, there was 20% of the patients who did not return to work in 6 months when they have heavy manual work. So it's very different if the patient is going back to office work or heavy manual work. So other factors that will have impact on sick leave is also female gender. And as I said, heavy manual work, and if the patient had persistent bursitis. So to the clinical evaluation. We know that pseudoparalysis can say us something about how the possibility to repair the cuff. And there's always a discussion, what is actually pseudoparalysis? Some say it's 45, if the patient is unable to elevate the arm more than 45, some say 90, but I think we can agree on that for most of these patients, there's one of the cables ruptures at least, and the passive movement is, for most of them, normal, and the restricted active motion is not dependent on pain or stiffness. And the leg sign also influences the reparability. If you have a positive leg sign in either position, this should be a warning that it's associated with irreparability. So to the radiological evaluation, most of us always do ordinary X-ray in addition to the MRI. And when you consider the superior migration of the humeral head, most of us use the Hamada classification. And this is based on normal anterior posterior X-rays. So when I hear some colleagues use the MRI to consider this distance, I think this is not accurate, because then the patient is lying supine, but in the ordinary X-ray, the patient stands erect, and when you then see the migration, this is a sign that the patient has a chronic tear. So for stage 3, 4, and 5, I think you will have a very little chance to succeed if you try to repair those cuffs. We also have to think about the fatty infiltration, of course. Most of us call it the Gutelier stages. That's actually based on CT scan. When we use MRI, it's Fuchs classification. And grade 0 and 1, perfectly okay. You can try to repair those. Grade 2 is a little bit more debated, but I think most of us will probably try. But is it a grade 3 or 4? You will most probably not succeed repairing. And we also have the tangent sign, the supraspinatus belly in the supraspinatus fossa in the sagittal view. You draw a line from the acromion to the coracoid, and if the muscle belly is lower than this line, this is a predictor that your cuff repair will not heal. So in this work from Kim, they tried to predict the irreparability. They published material from 758 patients from Korea, and they tried to determine what risk factors mean most to us when we will try to predict if we can repair or not. And you can see all the factors, we have talked about them. It's gender, it's pseudoparalysis, it's medial to lateral size, acromiohumeral distance, and so on. And they stipulated that the irreparability rate was 12.5%. These are the same study put in a form, and you can see they have divided these factors in the repairable group and irreparable group and analyzed retrospective. So those who ended up in the irreparable group, they were older and they were more female. There were 37% having pseudoparalysis before the operation, compared to only 6% in the repairable group. And also the size, medial to lateral and anterior-posterior size, much bigger in the repairable group. And the acromiohumeral distance, 9 millimeter in the repairable group before the operation, and less than 6 millimeter in the irreparable group. Tangent sign, very different, 3% in the repairable group, more than 60% in the irreparable group. Fatty infiltration, as we talked about, 60% in the irreparable group, and also the tendon involvement, how many tendons meant something to if it was repairable or not. So first they did univariate analysis, and the factors I presented in the last slide were those who had significant differences. And then they used these variables in a multiple logistic regression to try to find out what was the most independent predictors for irreparability of the cuff. And top of the list was the tangent sign, then the acromiohumeral distance, and then the mediolateral tear size. So that's very important factors when you predict whether you can repair or not. And then it was the involvement of the chronic pseudoparalysis, the involvement of 3 tendons, and fatty infiltration, Gutelier stage 2 or more. So they calculated an equation. It's a long, complicated formula. I can't even remember it. So hopefully they will put all this in an app so we can just push the button and get the predictability if we should repair or not. If we turn it the other way around, when we plan our surgery, we also wonder if we can make this tear to heal. So we can also look at the possibility of re-ruptures. And the best predictors for re-ruptures, in addition to the factors we have already mentioned, is also the tear thickness, because total tears, they tend to re-rupture more often than the partial tears, and also the operation time. If we use very long time in the OR, this is a predictor that the patient might have a re-tear. There's also a group, Crohn, that have worked on a healing index to help us to calculate whether the cuff will heal or not. and they are given points. You see the retraction medial of the cuff is the value that gives most points. It gives 4 points, and also all the factors we have already talked about, including bone mass density. We have talked a lot about the bone quality earlier today, so that's also a factor that is in this healing index. And totally, it's possible to get 15 points. But if you have less than 4, you can say that it's 6% chance that you, only 6% chance that you will have a re-rupture. But if you have more than 10 points, it's almost 90% chance for a re-rupture. So this is my last slide to sum up. The factors very strongly associated with irreparability is age and comorbidity. It's chronic pseudoparalysis before the operation. It's the size of the tear from medial to lateral. It's the acromiohumeral distance, the tangent sign, the fatty infiltration, and how many tendons involved. Thank you so much for your attention.